Margaret waited 2 weeks in a hospital bed for her hip surgery approval. Every day, her Medicare Advantage plan promised a decision was coming tomorrow. Meanwhile, her hospital room charges accumulated. When approval finally came and the surgery was performed, Margaret received a shocking bill. Her insurer charged her for an unnecessary extended hospital stay caused by their own delays. The total out-of-pocket cost, over $8,000. This wasn't the zero premium experience she had signed up for. What if everything you've been told about $0 premium Medicare Advantage plans is fundamentally misleading? What if the promise of free coverage is actually an elaborate financial trap that could cost you tens of thousands of dollars when you were most vulnerable? Today, we are going to uncover the shocking truth behind what might be the most brilliant marketing deception ever perpetrated on America's seniors. The appeal of a zero premium Medicare plan is undeniably powerful. For millions of American seniors facing significant financial insecurity, the promise of health coverage without an additional monthly cost seems like an ideal solution. This attraction is so strong that more than half of all eligible Medicare beneficiaries are now enrolled in Medicare Advantage plans, with low upfront costs being a decisive factor. But this seemingly simple offer raises a fundamental question rarely addressed in glossy advertisements. If the premium is zero, who's paying, and what are the hidden costs? The answer reveals a complex system where what appears to be a bargain for the individual ultimately costs everyone more, especially when serious healthcare needs arise. Let me be clear. These plans aren't free. They exist because of a complex government payment system that subsidizes private insurers, creating a product that's actually more expensive for the Medicare system as a whole, even while appearing cheaper to the individual initially. Here is how it works. Medicare Advantage plans aren't government insurance. They're private insurance plans run by for-profit companies that contract with the federal government. The Centers for Medicare and Medicaid Services, CMS, pays these insurers a fixed monthly amount for each enrolled beneficiary to provide Medicare benefits. The $0 premium is made possible through a 3-step process involving bids, benchmarks, and rebates. Insurance companies submit bids to CMS representing their estimated cost to cover Parts A and B services for an average beneficiary in a given area. CMS then establishes a benchmark, the maximum amount the government will pay for a beneficiary in that specific county. If the insurer's bid is below the government benchmark, which happens in the vast majority of cases, the insurer receives a percentage of the difference back as a rebate. These rebates are the secret sauce of the zero premium model. In 2025, average rebates exceed $2,250 per enrollee annually. Insurers must use these funds to benefit members, either by reducing premiums, often to zero, lowering cost sharing, or offering so-called extra benefits like dental and vision coverage. The existence of these plans isn't a sign of private market efficiency, but a direct consequence of a payment system where Medicare pays private insurers significantly more per person than it would spend on the same individual in original Medicare. Analyses from the Medicare Payment Advisory Commission, MedPAC, estimate that in 2025, overall payments to Medicare Advantage plans are 20% higher than spending for similar beneficiaries in original Medicare, translating to $84 billion in additional federal spending. A critical truth that marketing often obscures is that a $0 premium plan doesn't eliminate all premiums. Regardless of which Medicare Advantage plan you choose, you still must pay your monthly Medicare Part B premium directly to the government. For 2025, the standard Part B premium is $185 monthly. In our next section, we all explore the first shocking revelation, how the real out-of-pocket costs of these $0 premium plans can devastate your retirement savings when you actually need care. We'll uncover how these plans exchange predictable upfront costs for potentially high and unpredictable costs at the moment of use, a dangerous financial gamble for seniors on fixed incomes. The appeal of a $0 premium can quickly evaporate when a beneficiary actually needs medical care. The financial structure of these plans trades predictable upfront costs for potentially high and unpredictable out-of-pocket expenses at the moment of service. This reversal of financial risk is particularly dangerous for seniors on fixed incomes, who may be attracted by the monthly savings without fully understanding the catastrophic financial risk they're reassuming. The business model of low-premium Medicare Advantage relies on cost-sharing for nearly every service. Instead of paying a higher monthly premium, members pay as they use health services. The key terms to understand are deductibles, the amount a member must pay out of pocket before the plan starts covering costs. While many Medicare Advantage plans advertise $0 medical deductibles, they often have prescription drug, Part D deductibles, which can reach the maximum of $590 in 2025. Copayments, fixed dollar amounts paid for specific services. For example, a plan might require a $20 copayment for a primary care physician visit and $50 for a specialist visit. Coinsurance, a percentage of a service's cost. For instance, a member might be responsible for 20% of durable medical equipment costs or certain outpatient procedures. Medicare Advantage plans offer one feature original Medicare doesn't have: an annual maximum out-of-pocket (MOOP) limit, which is the maximum amount a beneficiary will pay in a calendar year for services covered by Parts A and B. While this functions as a safety net against unlimited costs, the amount of this cap can be shockingly high. The federal government-set maximum MOOP for 2025 is $9,550 for in-network services and can reach $14,000 for PPO plans covering out-of-network services. Although the average plan MOOP is lower, around $5,320, the risk of hitting the legal maximum is a real possibility for anyone facing serious illness. Thomas Anderson from Raleigh never worried about his $0 premium plan until he was diagnosed with lymphoma at age 72. "I thought I was saving money every month," he explains. Then came the hospital stay with daily co-payments, chemotherapy treatments with 20% coinsurance, and specialist visits at $50 each. By August, I'd hit my plan's out-of-pocket maximum of $6,700. My free plan cost me nearly $7,000 in just 6 months. Crucially, prescription drug costs don't count toward this medical MOOP. As of 2025, Part D drugs have their own separate cap of $2,000 annually, thanks to the Inflation Reduction Act. Therefore, a bad health year could expose a beneficiary to up to $9,350 in medical costs, plus $2,000 in drug costs, totaling over $11,000 in out-of-pocket expenses. The financial costs of Medicare Advantage plans aren't the only price members pay. They also sacrifice significant control over their own healthcare decisions. The managed care model, central to the MA cost structure, imposes restrictions through provider networks and a gatekeeper system known as prior authorization, which can create barriers to timely and necessary care. Unlike original Medicare, which allows beneficiaries to see any doctor or hospital in the US that accepts Medicare, Medicare Advantage plans operate with defined provider networks. The two main types are HMO, Health Maintenance Organization. This is the most restrictive model. Members must use in-network doctors, specialists, and hospitals for services to be covered, except in emergencies. A referral from a primary care physician, PCP, is typically required to see a specialist. The lowest $0 premium plans are often HMOs. PPO, Preferred Provider Organization. This model offers more flexibility. Members can see out-of-network providers, but will pay significantly higher out-of-pocket costs. Referrals for specialists are generally not required. A critical risk many beneficiaries don't realize is that these provider networks aren't static. They can and do change every year. A doctor or hospital that's in network this year may not be next year, forcing members to a difficult choice: find a new doctor or switch to a new health plan during the annual enrollment period. Perhaps the most controversial and impactful restriction is the prior authorization requirement. This means the insurer must give permission before a doctor can perform a service, test, or procedure. While insurers claim this is necessary to prevent unnecessary care and control costs, The reality for patients can be a bureaucratic nightmare. This process routinely results in dangerous delays and outright denials of care that physicians deem clinically necessary. Real-life accounts illustrate the human cost. Elizabeth Kim from Portland waited 2 full weeks in the hospital for approval of hip surgery, only to be charged by the insurer for an excessive stay caused by the insurer's own delay. Barbara Nelson from Seattle was literally on the operating table, sedated and prepped for surgery, when the hospital was notified approval had still not been granted. In our next section, we'll expose the third shocking truth, the reality behind those extra benefits that are so prominently advertised. We'll discover how dental, vision, and hearing coverage often come with severe limitations that diminish their actual value, functioning as psychological tools to distract from the more significant risks and compromises in the core medical coverage. The extra benefits like dental, vision, and hearing coverage are the most effective marketing tools in the Medicare Advantage arsenal. Since original Medicare doesn't cover these routine services, their inclusion in MA plans is a major draw. However, closer examination reveals these benefits are often superficial, with significant limitations that diminish their real value. They function as a psychological tool to divert attention from the more substantial risks and compromises in the core medical coverage. The promise of dental coverage is one of the primary reasons seniors choose MA plans. However, the reality of coverage often fails to match marketing expectations due to several limitations. Low annual limits. Most plans impose a cap on the total dental benefits they'll pay in a year. These limits are frequently low, typically between $1,000 and $1,500. Considering that a single major procedure, like a crown or root canal, can cost more than the entire annual limit, coverage can be exhausted quickly. Limited scope. Coverage is often structured in tiers. Preventive care like cleanings and x-rays may be covered at 100%, but major services like fillings, extractions, crowns, or dentures are covered only partially, perhaps at 50%. This leaves the beneficiary with a significant out-of-pocket bill for anything beyond routine maintenance. Restrictive networks. To receive any coverage, members must use dentists who are part of the plan's specific and often limited network. A beneficiary's longtime family dentist may not be included, forcing a choice between switching dentists or paying 100% out of pocket. Like dental coverage, vision and hearing benefits are a big draw since original Medicare doesn't cover routine exams, glasses, or hearing aids. However, the actual coverage is similarly restricted. Frequency limits. Coverage for routine eye exams is often limited to 1 per year or every 2 years. Small allowances. Plans don't fully pay for eyeglasses or contact lenses. Instead, they offer an allowance, a fixed dollar amount, like $150 or $250 toward frames and lenses. Any cost above this allowance is the member's responsibility. With the cost of modern eyeglasses, this allowance rarely covers the full amount. Many MA plans also offer wellness perks like the Silver Sneakers Fitness Program or debit cards for over-the-counter OTC items. These benefits are legitimate and valued by many members. However, they should be viewed as secondary advantages. The decision to choose a health plan that may restrict access to critical medical care should not primarily be based on the availability of a free gym membership. The marketing strategy encourages beneficiaries to make a high-risk decision about their cardiac or oncology care based on a low-risk benefit for their teeth and eyes. To make a truly informed decision, beneficiaries must understand the primary alternative to Medicare Advantage plans. This alternative, comprising original Medicare combined with a Medicare supplement insurance, Medigap policy, offers a fundamentally different philosophy of health coverage, prioritizing cost predictability and freedom of choice over lower monthly premiums. The alternative to MA is staying in the government-run original Medicare program, Parts A and B, and purchasing a Medigap policy from a private insurer. This model offers several distinct advantages. Predictable costs. With this approach, the beneficiary pays a higher and fixed monthly premium for the Medigap policy. In exchange, the Medigap plan covers most or all Medicare out-of-pocket costs, such as deductibles and coinsurance. For example, the popular Plan G covers all Medicare out-of-pocket costs after payment of the annual Part B deductible, $257 in 2025. This makes health expenses extremely predictable. Maximum freedom. The primary benefit is freedom of choice. A beneficiary can see any doctor or hospital throughout the US that accepts Medicare. There are no provider networks to worry about, no gatekeepers. There is no prior authorization requirement for Medicare-covered services. Treatment decisions are made between the patient and their doctor, without insurer interference. The choice between MA and Medigap comes with a critical and often irreversible caveat. In most states, after the initial 6-month enrollment period when someone first enrolls in Medicare Part B, insurers can use medical underwriting to decide whether to sell a Medigap policy. This means they can deny coverage or charge much higher premiums based on a person's health history. This creates a trap known as golden handcuffs. A healthy person who chooses an MA plan at 65 to save money may find they cannot switch to a more comprehensive Medigap plan at 70 if they've developed a chronic health condition. They may be stuck in their MA plan even if it no longer meets their needs. This is a monumental decision with long-term consequences. In our next section, we'll conclude with practical guidance on who might be appropriate for a $0 premium plan, who should be cautious, and how to protect yourself with a due diligence checklist if you're reconsidering Medicare Advantage during the annual enrollment period. The detailed analysis reveals that $0 premium Medicare Advantage plans aren't a one-size-fits-all solution. The suitability of such a plan depends entirely on an individual's health, risk tolerance, and financial situation. The decision to enroll should be based on a clear understanding of the trade-offs, not just the attraction of the monthly premium. Based on the evidence, a $0 premium plan may be a reasonable choice for a specific profile of beneficiary, very healthy, someone who rarely utilizes medical services beyond preventive care. For this person, the likelihood of incurring significant out-of-pocket costs is low, making the monthly premium savings attractive. Financially prepared and risk-tolerant. Someone who has substantial savings and can comfortably afford to pay the maximum out-of-pocket limit of up to $9,350 in a bad health year, without it causing financial devastation. Local and stable. Someone who doesn't travel extensively and whose trusted doctors and hospital are confirmed to be part of the Plan S network. This person should also understand that the network may change annually and be willing to adapt. On the other hand, certain individuals face significantly higher risk with a $0 premium plan and should consider their options with extreme caution. Individuals with chronic conditions. Anyone dealing with diabetes, heart disease, cancer, or other chronic conditions requiring frequent specialist visits, tests, and complex treatments. For them, co-payments and co-insurance can add up quickly, and prior authorization barriers may impede access to necessary care. Those who prioritize choice. Anyone who wants to ensure the ability to see a top specialist or renowned cancer center anywhere in the country if they receive a serious diagnosis. The freedom to seek the best care, unrestricted by networks, is incompatible with most MA models. The financially vulnerable. Anyone for whom an unexpected medical bill of several $1,000s would be a financial catastrophe. This group, representing a significant portion of the senior population, is most susceptible to $0 premium marketing and most harmed by its out-of-pocket risk structure. To empower beneficiaries to make the best decision during the annual enrollment period, October 15th to December 7th, the following due diligence checklist is essential. Check your doctors. Don't assume anything. Use the Plan S official provider directory to confirm that each of your preferred doctors, specialists, and hospitals is in network. Check your prescriptions. Use the Plan S drug formulary to ensure all your medications are covered and at what cost tier. Calculate real cost. Ignore the $0 premium. Add up the co-payments and co-insurance for services you expect to use, and more importantly, understand the financial risk of the maximum out-of-pocket limit. Investigate the extras. Look for the actual dollar limits of dental and vision benefits. Is a $1,000 dental limit worth giving up your choice of doctor? Understand the irreversible choice. Recognize the Medigap trap. Realize that choosing an MA plan now may prevent you from getting a Medigap plan later if your health changes. Joseph Rodriguez from Minneapolis learned this lesson the hard way. I chose Medicare Advantage at 65 because it seemed like a great deal. At 72, after developing heart problems, I wanted more freedom to see specialists without referrals. But when I tried to switch to a Medigap plan, I was denied due to my pre-existing conditions. I am now locked into a system I no longer want. The most critical caveat that few insurance agents discuss is this. In most states, after your initial enrollment period, you have only one guaranteed opportunity to choose a Medigap policy without health questions. After that window closes, insurers can deny you coverage or charge much higher premiums based on your health conditions. This creates the golden handcuffs scenario where a healthy person who chooses Medicare Advantage at 65 may be unable to switch to Medigap at 70 if they've developed health problems. They become permanently locked into the Medicare Advantage system, regardless of whether it continues to meet their needs. If you found this analysis valuable, please help others make informed decisions by liking this video and subscribing to our channel. We recommitted to providing straightforward, strategic advice that helps you navigate complex healthcare decisions with confidence. In the comments below, share your experience with Medicare Advantage or any questions about the $0 premium model that we can address in future videos. Remember, the best healthcare decision isn't about getting the lowest premium. It's about securing reliable, accessible care when you need it most.